Hello, everyone, and welcome to this session of the AI Nurses Network webinar series. We have a great colleague with us, Ann Wieben, today, who's going to talk about her work in artificial intelligence in nursing. So over to you, Ann.
Okay, thank you for having me. Very excited to share some work with everyone and hope for some future collaborations. Okay, so just a little bit about me, because I always think it's interesting as nurses and nursing informaticists, and even nurses working in AI to kind of know how we got here. I actually grew up on a farm, so that's me in the very top left corner, being a lucky kid and feeding a baby calf, one of 9 children, first generation college students, so not a given that I would end up talking here with you today. Even though this is a straight line, I didn't have a very direct path to nursing. It was a little windy. I actually have a bachelor's degree and a master's degree more related to environmental science and worked in that field for a while. For those who don't know this bird, this is a common loon that are very full in our lakes here in Wisconsin, which I'll show you where I live in just a moment. So I did work with common loons. Those were my first blood draws, actually, before I became a nurse, and also some water quality work. But then eventually came to nursing and got my bachelor's degree in nursing and worked as a clinical research nurse for a time. And then as a nursing informaticist, I think my work in environmental science dovetailed well into a role as a nursing informaticist because I already had a lot of experience working with big data sets and analytics and whatnot. And then eventually pursued my PhD in nursing. And during my time in my PhD is when I got involved in AI research. I came into the PhD program thinking I was going to study a whole another topic, but was working as an informaticist for the Academic Medical Center at the time as well, and got assigned a sepsis predictive model that I needed to be the project manager for this implementation and learn all about it. This machine learning model and those whole concepts were really new to me, so I learned a lot. And as a result of all the questions I had with that project, I sort of shifted my whole focus of my PhD dissertation, ended up getting a minor in industrial engineering, took a lot of data science courses, et cetera, and made that shift just kind of based on that practical experience of having so many questions when trying to implement this sepsis predictive model. So that really informed my work and my current direction. So I know this is sort of an international audience, so I just wanted to let you know where I am within the United States. So Madison is a small but well-kept secret. If you ever get a chance to visit us, it is lovely. It's about 300,000 people. There's 4 lakes right in the city. It's a really big university, the biggest university in Wisconsin, so about 50,000 students. And really just a lovely place to live, about 2 hours north of Chicago, if that helps orient you at all. But this is where I'm coming from. There is a certain, for this audience that might be of interest as well, a big EHR vendor that is also located in Madison, and that makes it kind of interesting to teach and research informatics here. And this is just a bird's eye view of our campus. So as you can see, it's sort of nestled between 2 lakes, very green, very bikeable. So really, again, a great place to be. So if you're ever in the area, please come visit. It's a wonderful city. So this is my why. I don't know if any of these reports got to others around the world, but we've had a couple of instances of nurses in the United States protesting against the use of AI in their hospitals. This is one example from 2024. There was another more recently with nurses in New York. And again, this isn't to say that these nurses are anti-AI, but what they are is pro-human, and they have a lot of concerns about the way things were being implemented, oftentimes not with their input. And they just had concerns about both their, the quality of their own work with these tools in play, concerns about their patient safety, and just really wanted to be at the table when these tools are chosen and intersecting with their own practice. So I really applaud these nurses. I think it's unfortunate that it had to come to these kind of actions for them to be heard, but I do really admire, them standing up for their concerns. So my hope is to get nurses more at the left, so really involved in co-design, very upstream. I do think some of these tools have great potential, but it's going to take a lot of thoughtful people to make sure that tools are implemented well. And any tool that's going to touch nursing really needs to be designed with nurses, and they need to be a part of the teams at every step of the way. So my program of research, I have currently these key foci. I mean, I'm looking to critically examine the integration of AI technologies into nursing practice. I really oscillate myself on how I feel about these tools, both in nursing and for the broader humanity. I have times where I'm really curious, really excited about the potential, other times where I get really worried. Maybe many of you feel that way as well. So I'll kind of step through some of my past and current ongoing studies that relate to these, again, three key foci: performance of nurse AI team. And actually, I meant to sort of edit that slide because I'm trying to think about the way I talk about AI lately. And I don't know that I like to give AI sort of human qualities as well as being a team member. So I did change this on the next slide, but so that's just something that I'm also thinking about, just remembering that these are computers and math and algorithms, and we have a tendency to anthropomorphize them. And I worry if we look to the right and we're thinking about trust in AI, that might lead us to sort of over trust if we give them too many of these human qualities. So as I'm looking at my slides, I'm thinking about that and how my own language is, I'm trying to evolve over time and how I'm thinking about these tools and talking about them. And then I'm also interested in how do we evaluate AI? Not just safety and accuracy, although those things are all really important too, but more holistically as nurses, when we're looking at our own professional standards, our values, our ethics, thinking about the nurse-patient relationship, and really trying to broaden, in nursing, our evaluation standards. So with that, this is my research roadmap. So the studies in blue, I'll briefly touch on, where I really this was kind of my dissertation work. So really just trying to understand nurse perceptions of AI. So I have a qualitative and a quantitative study where I kind of gathered nurse perceptions and satisfactions with explanations for AI. And I'll touch base on those studies in just a moment. And then currently, I have another study that I need to get that paper out where I sort of looked at performance of nurses using AI in a high fidelity sort of usability study, but not in, real world setting. And then I have a current study looking at working with nurses to co-design an evaluation framework for generative and ambient AI. And then I'm interested in nurse trust in AI, but that's kind of a future state. So this is sort of where I'm at right now in my research roadmap. So again, first I'll just touch base briefly on these two studies from my dissertation. These are published, so I'll spend a little less time on them. I'll leave this up here for just a moment in case you want to grab any of those QR codes and check those out. But you're welcome to do so. And I just want to acknowledge all of my wonderful colleagues here that also worked with me on these studies. You can see their names there. So the first one, nurse perceptions in AI, it was really a qualitative study, just sitting down with nurses. So again, keeping in mind that this is before the large language models came on the scene when we were working with old-fashioned AI, machine learning models, predictive risk tools, was primarily what I was talking about. Some more machine learning driven decision support tools, tools that predicted risk of sepsis or readmission or risk of falls was kind of the target discussion with nurses for this study. So I just sat down talking with 17 direct care nurses, over an hour each one, just trying to understand, where they were at as these tools were becoming more and more common in care settings. I learned through this study and talking to them that their experiences in this whole technology ecosystem really influenced their receptivity of new tools. I will say, working as an informaticist, we do a really good job of putting decision support and lots of tools in the systems, but we're really bad at taking them out. And then as we, many probably already know, there's issues with alert and alarm fatigue that come into play. And it kind of, it makes it hard for nurses to see the forest through the trees when there's so many different data points that they're kind of supposed to validate and take care of. Then nurses talked about how they really, wanted the machine learning CDS to, they need to know the why behind it. And that doesn't always get conveyed in all of these projects in terms of why that tool's there and also what to do with it. So a lot of times these risk scores got put into play, but there really was no connection to the next steps in the care pathway. And that was a big fail for the nurses. Not that they wanted like, if this score do this, but they wanted some direction. Okay, if this score, think about, these potential actions, just to kind of help them understand next steps. Because I can remember one quote very specifically for this study. So, the nurse essentially sees the score and they're like, well, okay, now what? Like, what do you want me to do with that? Especially again, when there's so many of them in play. So again, just informing about design in terms of what nurses need, but really, and then again, nurses having, questions about their own autonomy, when it's okay to, just basically disregard a risk when they've done their own more holistic assessment of what's going on with that patient and just contending with that. So again, a great initial study for me to just hear more from nurses at this time about their perceptions of these tools. And then the next study I did was a web-based factorial survey with clinical vignettes. So over 300 nurses participated in this one. And essentially, this was built into a Qualtrics survey. So they could just do this wherever they were. They read through description of a machine learning decision support model and a patient scenario, and they reviewed an explanatory information display. And this was sort of the question that I was trying to get to here. So when I, again, as I mentioned, was working on this sepsis predictive model and then was ultimately assigned additional models to work on in my time as a nurse informaticist, I'd get asked, like, how do you want like the explanatory display to look for nurses? And I'm like, well, I'm one nurse. I can't decide for all nursing what nurses want. And I also wondered if, there was some characteristics of the nurses that might be important. So their own numeracy or graphical literacy that might, sort of influence what type of display they might need. So I had constructed 8 different displays that varied by like simplicity versus more complex, and then more tabular versus graphical, and just tried to assess, what nurses preferred and whether or not, these displays really kind of met their needs for understanding this machine learning CDS. The display at the bottom is just one of the very simple examples, and then there were some more complex ones. And then again, so they would get randomized to a clinical scenario, either deterioration or falls, and then randomized to a type of display, and then answer the explanation satisfaction scale, as well as information about them. And again, you can read the paper to get more details. This is just one little piece of it, but this is pretty common. There wasn't a big difference between the simple or complex explanations or the tabular or graphical, but some of the, the response averages that we see here were common across all the displays. In particular, again, this kind of lends itself to my previous study where it's really kind of falling short on how to use the machine learning CDS, these explanatory displays. So again, we're kind of failing to make that connection to the care pathway sometimes with these tools. Interestingly, they also really kind of rated it lower on understanding the accuracy of the machine learning model. They were provided with sensitivity and specificity information, or like a confusion matrix, so like number of true positives, false positives, true negatives, false negatives, etc., but didn't sort of equate that to the accuracy of the tool, or that wasn't enough. So again, that made me curious about if we need to teach nurses more about that, because model cards often have that kind of information, but maybe that's not meaningful to nurses, at least not at this time or my participants. And then finally, with the trust, this low response on trust didn't really surprise me. They only got to see one display. I think this is something that builds over time as nurses use these tools. So again, not maybe a great measure in a factorial survey type study, but definitely something of interest like in the real world as they use tools over time. So again, if you want to check out those papers and learn more, there's more details inside, but that just gives you an idea of sort of how I got started with this work. And then I'll talk a little bit about where I am going next. So this is a study, again, kind of still working with machine learning clinical decision support. But in this case, we tried to do a high fidelity simulation study where they worked in basically a non-production electronic health record. So we could compare how is actually nurses and medical residents, how they performed in a patient prioritization task when using a machine learning decision support tool versus their normal EHR clinical review workflows. So again, as we know, machine learning models are very common in healthcare systems today, but their impact on clinician performance has yielded pretty mixed results. So as I mentioned, we're looking to see if it can help with either efficiency or effectiveness or satisfaction when conducting this patient prioritization task. So in this case, this is a tool that's out there. This is the tool we were testing. It's called eCart, and it's a cloud-based software, and it looks to anticipate clinical deterioration in adult patients. This is a little bit about the model type and the inputs that you can see. I won't spend a ton of time on that, but essentially, again, presenting a risk score. This tool is nice because it does have sort of a deeper once you click on a score, you get more information. And this one does do a pretty good job of connecting clinicians to the next steps in the care pathway. It sort of has a decision flow diagram that they move into and sort of document within. So if of interest, you can check it out. It is a tool that is doing a little bit more about, some of the shortcomings that I saw with my other studies. I do think this tool is doing a pretty nice job with addressing some of those concerns that that nurses had reported. So again, we had both nurses and medical residents come in to our laboratory and had a non-production version of the EHR that they worked with in their own care settings. Again, this limitation, it was just one academic medical center, but essentially they reviewed training documents about the tool. Some of them had experience with the tool in practice and some did not. So that was definitely something that we were sort of tagging in our analysis. They reviewed the health records of 5 synthetic patients. And then they prioritized the patients by their level of concern and identified their recommended next steps in that care pathway. And they filled out a bunch of questionnaires, demographics, after visit questionnaire, the NASA TLX, which is sort of an standardized effort measure, and then the computer system usability questionnaire, only for the session that added the machine learning model tool. And then just answered some open-ended interview questions about their experience using the system. So again, we were looking at effectiveness, we were looking at efficiency, so time on task, clicks and scrolls. We were looking at some of their perceptions, their satisfaction and confidence, their perceived task load, usability, and then we just analyzed those with just descriptive statistics and Wilcox and sign rank tests to compare differences between the sessions and the type of participants. So this study is not quite out yet, but I will share that simulation environment, at least for us, and I don't know if others have better ways to do this. I'd love to hear from you. So, I found that this is the first time at our organization that we had really set up sort of a simulation environment that was high fidelity. So it brought with it a lot of challenges. I mean, these data are coming in really dynamically to trigger these displays. This machine learning decision support tool has a trend line. So we did need like 72 hours of data prior to the start of the session. We wanted them to look the same for every participant. So we sort of had to adjust based on the start time of the session. So lots of things to sort of unpack in terms of getting all the different triggers into the simulation system that we worked through. Now that we have it down, we can do this more easily at our institution, but it did take quite a lot of time actually to figure all of that out. And then this is just an example of what I mean by lag. Like this is all the data and sort of the back timing that we had to do and how to think about getting it into the system. So it seems simple, but in reality, getting all that data into the system wasn't as easy as one would think. We ended up using like virtual devices to sort of get the vital sign and assessment data that we needed into the system, and then creating a synthetic external lab and using HL7 messages to get the laboratory data in. And again, it wasn't, if the data was static and the timing was static, it would have been a lot easier, but because we had these dynamic start times to meet the needs of the participants, that was the added layer of complexity that we were really working through. So just something to think about if you're thinking about doing simulation studies. You can reach out because I think we figured some of this out, but it was something that took us longer than we anticipated. So again, the results for this study are not quite published yet. I hope that paper will be submitted this summer. So I'm not going to share too much on the screen right now. I will share, we basically found no significant difference in performance between the EHR and the addition of the tool. We did see though a significant increase in confidence. So I found that kind of interesting, sort of this discrepancy between the performance and the confidence. I guess maybe it's reaffirming what they already thought. I mean, in both sessions, the clinicians were very high performing. So again, maybe that's the limitation of doing some of these things in a simulation environment. They had as much time as they wanted, so they could really review the charts. No real big difference in task completion time, although if I look at my data, there's a lot of variation there. Like some were a lot quicker with that machine learning model in play. Some were slower with it in play because they basically just added it on to their normal chart review. So that varied a lot by participant. So still looking to sort of unpack some of those differences based on like prior experience with the tool and whatnot. So again, just another example of another way we can explore these tools. But it was a lot of work for the simulation environment, and I'm still weighing whether or not I think it's valuable versus just trying our best to examine and do research on these tools in practice, because I don't know if we can really represent the complexity. That's still something that I'm thinking a lot about. So would love to discuss and hear what others think. And this is another study that I am currently underway with, where I'm working with direct care nurses to co-design a holistic AI evaluation framework that really centers on nursing practice, values, and ethics with direct care nurses. So again, this is my title with funding from my School of Nursing, which I really have appreciated to get this off the ground. I've currently worked with 2 sites and plan to work with 1 more, so this is still in progress. So again, I think we all know generative AI is coming very quickly into our healthcare settings, including nursing practice. There's a lot of tools out there. There's also evaluation frameworks out there. But again, I think as nurses, we want to be assessing these tools a bit more holistically than the evaluation frameworks that I'm seeing so far in the world. So again, really wanting to co-design these frameworks with nurses, think about processes to foster their involvement early and often, and exploring even organizational characteristics. So I'm doing this at 3 different sites. So thinking about their own local governance structures and how that kind of intersects with evaluation planning for AI. And then again, looking to ultimately come out with some co-design evaluation tool prototypes, like an evaluation framework and a rubric for nursing generative AI applications. So this used a participatory approach and co-design methodologies. And again, this was focus groups, co-design activities. We did some mind mapping, some nominal group techniques, and different consensus building strategies. So again, 3 sites, a rural nonprofit community hospital, an urban level 2 trauma center, and then this is serving primarily a rural area in a smaller city, and then an urban level 2 trauma center as part of a multi-state health system, so a much bigger organization. So trying to capture some of that variability as well. All direct care nurses being part of the study, I aimed to get 8 per site. Didn't quite get that much at the small rural hospital, but still really got a lot of great insights from that group. And then my other additional plan with this study is to recruit 1 direct care nurse from each site to be a member of the research team and really help me consolidate, across the 3 sites into that final framework. So again, just some overview of study activities, how I carried this out. So you can see that there again. I did do a little teaching about AI just to kind of level set for the group, and then discussed the technologies, things that nurses were hoping these technologies might do, things that they were concerned about, and then discussed the need for the generative AI framework and started some initial brainstorming about constructs that might be helpful or components of a framework. And then we really dug into it in that second session, again, using nominal group techniques to make sure I was kind of hearing from everyone, because as we all know in focus groups, some people like to talk more than others. And then really, again, dug into groups and began building out some of these prototypes. And you can kind of see just some photos of the great work the nurses were doing. They had a lot of fun with this, actually. So they're, kind of putting their constructs together, kind of, thinking through what's most important. If you see the little dots, that's them sort of voting with the dot voting in terms of what, the things they thought were most important. So again, so I have a lot of really great, different data artifacts for this study, like you're seeing here, as well as the audio recordings that I'm really excited to work with this last site this summer and then get this work out and all the great work these nurses are doing. So again, we'll still be doing additional data collection and inductive thematic analysis on some of those audio recordings and ultimately coming up with these prototypes with the nurses. One thing I can share that I'm finding that I was hoping to find, but nurses are talking about, not just safety and accuracy and cost and all the things that we would expect in an evaluation framework for AI in healthcare, but they're also talking a lot about impact on the nurse-patient relationship. As we have tools in the room, particularly ambient type tools, sort of listening in or watching, that they're concerned about. They even talked about concerns with the nurse-leader relationship, wondering about these tools then also maybe being used for surveillance of their own work and what does that mean. Also talking a lot about the potential environmental impacts, so the planetary health implications of these tools. So again, I'm hoping that the final framework will be more robust, more holistic, and really, again, ultimately nurse-led with their priorities in play. So again, I think I already talked about expected outcomes. So again, looking forward to finishing up this work this summer. And then I have another great opportunity to take part in a project related to ambient AI. So I didn't actually fill in the rest of this, but as I was thinking about it, preparing for this presentation, I realized it's sort of touching on all these aspects. And I know this is one that many folks are excited about. So we are working on next week. We go live with a pragmatic stepped wedged clinical trial of ambient listening for inpatient nursing, both nurses and nursing assistants, to see if it reduces documentation time. There's a QR code here, so we are trying to be very transparent and open with all of our materials as we're working through this. We've been working on preparing for this project since I think last October, November, and working very hard to get ourselves ready. So if you want to check out our GitHub, we have a lot of shared resources there, including the full approved protocol that we're using. that you can check out. It's also registered with clinicaltrials.gov in the US, so you can check it out there too, although our GitHub will have a lot more detail. So happy to have you share and discuss, how we might try to do more multi-site trials on these type of tools. So I assume most folks in the audience know about ambient listening for inpatient nursing. Obviously, these tools have been used a little more broadly for outpatient providers or health practitioners, but I'm excited to see interest by the vendors for also providing tools for inpatient nursing because, at least in the US, again, I'm not sure that I know for sure if it's true for all nursing worldwide, a lot of our documentation tends to be discrete, structured data fields. We often call that flow sheets here. So really what happens, there's a conversation between the nurse and the patient. We're kind of trying to talk about this as conversational care. So the nurse really talking through their assessment, what they're doing and what they're finding as they're working with the patient or recording any patient education, other aspects of care. That recording then gets transferred to the vendor and the transcript is made, and then that transcript is processed into those discrete documentation fields. So of course, this is just a very simple example, but these conversations can be very long and then creating many documentation fields. And then that data transfers back to the EHR. The nurse does need to validate all the fields and make sure they feel it's correct and make any needed edits or deletions based on any mistakes the tool might have made. So nothing goes into the permanent medical record until they've had a chance to review that. But the hope is that it can capture that nurses will spend less time documenting. Again, there have been some studies that show that nurses might spend up to 20 to 40% of their time documenting. Many of us didn't go into nursing to be typing on a computer, so there is a lot of excitement about these tools. So I feel very privileged to be able to study it in this way and see if it indeed is helping. So again, a little more of the background that many may know already. And some of these studies might be a little US centric. So again, I can't speak for documentation practices in nursing all around the world, but we are excited to see if this ambient listening, which is again using automated speech recognition and large language models, might be able to reduce that documentation burden experienced by nurses, maybe help with their professional well-being if that's the case. We are talking a lot about, okay, if nurses are saving time, what are we doing with that time? And hoping that it can mean the nurses can do some self-care or spend more time at the bedside with their patients. Hopefully not getting more patients. So again, this is a pragmatic randomized stepwise trial across 3 inpatient medical surgical units. So it's really kind of leveraging our learning health system that we have at our academic medical center, really kind of trying to break down some of the silos that we maybe had between operations and research. And we have operations folks and research folks on all of our work groups for this project. I, as one of the co-PIs, am heading up the analytics part, so we can provide research-grade analytics, not just for the study, but also for operations, for deciding down the road whether or not they want to expand this technology or not more broadly at their organization. Again, we're looking at registered nurses and nursing assistants, which I'm really excited about that inclusion, because I don't think we see enough about the nursing assistants in AI work. And then ambient listening tool, it's embedded in the EHR. And again, as I mentioned, nurses do review and confirm all the drafted documentation. And then our analyses will be using, well, I'll talk about some of the metrics here in just a second. So again, our primary metric, we wanted to rely on our documentation logs for this, not knowing how many nurses we'd be able to recruit into some of the other objectives that we had. That we are very interested in, but that's our primary. Just like, does it reduce the nursing staff documentation time? Is it really helping with that? And then we have a bunch of secondary objectives. We have a lot of exploratory ones too that I didn't include on this slide. We have a nurse scientist, or excuse me, we have a direct care nurse on the research team for this study. He's really been instrumental. I so applaud the health system for basically investing in some of his time to be part of the research team for this study. He's really interested in that click taps measure there. He really feels like that is where he spends a lot of time, and it sort of feels like death by 1,000 clicks. So that's a measure that he's excited about seeing go down if possible. And then again, we are recruiting nurses to take part in voluntarily in research surveys. Not quite sure yet. Our recruitment isn't going as well as we were hoping, so we'll see how many we actually get. But again, wanting to understand their professional well-being related to the tool being in play, their perceived usability of the tool. And then I don't list it here because it's more of an exploratory aim for us, but we do have like also a trust measure that we're doing at the end of the study to kind of assess their level of trust in the tool as well. And then this is kind of a busy slide, but I thought some folks might find it interesting to see an example of this is essentially an infographic of all the data tables that we're using in the study. We are looking at sort of de-identified patient level data, just wanting to know the types of patients that have been cared for throughout the duration of the study. Curious about preferred language or any hearing impairment status and how that might impact the use of the tool. Patients do need to consent to the recording, and we do let them know that AI is also in play. The nice thing about this is we document this upon admission, and then it's documented in a discrete field in the health record. And if they do decline, then that shuts off the tool. So a nurse just can be confident that they, even if they forget to check the consent, they're not going to be able to use the tool for a patient who does not consent. These documentation completion metrics came from some of our, our CNSs, our nurse specialists, who were curious if the ambient listening could help us capture more documentation that they think the nurses and nursing assistants are doing, but maybe forgetting or not finding the time to document. So we're kind of hoping to see an increase in documentation in some of those items. And then, of course, we're looking at adoption, the use of the tool. There is a feedback mechanism built right into the EHR with the tool where they can rate as well as provide free text on the drafted documentation and provide that feedback. So very interested to learn, what nurses think about the outputs through that. And then again, a lot of other metrics related to documentation latency, the work impact, and just, a lot of it's about time, of course, because that is something that we're trying to give back to nurses. And then you can see more of our specific research related studies. So again, this was a kind of a collaboration between operations and research, but working together on our data management plan and various dashboards and whatnot, which is kind of the little bubbles you see, or the type of dashboard that they'll be viewing, be able to view the data in. And then I do have some other work I just wanted to briefly touch on. I'm part of the American Medical Informatics Association, has a really wonderful nursing informatics working group. Despite the name of the organization, we would welcome international members to our group. And I've been working on that policy committee. So this is just an example of one of the papers that we put out where we're just trying to better understand the regulatory landscape for AI that might be impacting nursing practice. Unfortunately, in the US right now, we don't have a lot of federal level guidance. And as a result, we tend to have sort of state by state legislation either being proposed or implemented, which can make it really challenging. Some of our health systems are very big and they cross state lines. And this can make it really difficult for a nurse to know where these policies impact their practice. So again, you can check out this paper if you want to learn more. We were just really trying to understand, whether or not there was any legislation going on about nurse practice, whether, different things about like patient consent and transparency with patients, liability concerns we had. So again, for the sake of time, I can't get into too many details. One thing that we found interesting was that there are 2 states in the US, both Oregon and Washington, that have passed specific legislation protecting the title of nurse and preventing companies from selling an AI nurse or calling it an AI nurse or saying that it can provide nursing services. So really going the extra mile to protect the title of nurse in those states. And then I just came back from this conference last week. This is another one that I'm involved in that, again, we welcome international participation. This is called the Nursing Knowledge Big Data Science Initiative. And I think what I like about this work group, again, we also do like papers together and a lot of active things, all voluntary, but it's a great way to meet others in this space from all around the country and in the world. We do have a couple of collaborators in this group from Italy. But this is really kind of a core mission of this is just, really focusing on the data and the analysis of the data and the use of the data, the quality of the data in nursing, representing nursing value, as well as, thinking about AI tools. No AI tool is going to be any good if the data is not good. So really kind of coming back to that foundation. Of course, we're talking about AI in this group too, but really it comes back down to the data. So there's tons of work groups going on with this initiative. So if you're interested, be happy to have you join us there. It's a great group of people. And no matter where I am, I'm always sort of leaving with this slide. I actually just debated this at a conference with some colleagues where we debated whether or not a nurse needs to be a human being. We were all nurses, so of course we all think so, but we, for the sake of the debate, some of my colleagues were brave and did take the other side. But again, this is some of what we talked about, at least those of us, for the affirmative, that a nurse does indeed need to be a human being. Again, AI can some great potential to do some things and maybe can do a few things that a nurse can't do, but I think, the ability of a nurse to see possibilities for the future, the real purpose behind our care, the human story, that whole real person, and that human context, that embodied care, I don't see as replaceable. So I'm not worried about that as long as, again, nurses can be at the table designing, evaluating, selecting the tools that come into their practice. Then I think we're going to be okay and hopefully find a few useful tools to help us provide better care, because that's really, as we know, what it's all about. So with that, I think that's a wrap and enough of me talking, but I'd be happy to connect with you. I'd love to build international partnerships. Again, I'm an assistant professor at the University of Wisconsin, and just looking to work together to understand these tools better and really just work together to foster nursing practice and nurses. So I guess with that, should I stop sharing?
Oh, you can leave up your slide and just in
Leave
case
that up there? Okay,
yeah,
sure.
just if people want to grab your details. But thanks so much. That was really interesting. You sound very busy.
Yes. No doubt about it, but it's fun.
Yeah. Well, you actually answered the first question I have was about how you got interested in AI. So thanks so much. It's so interesting. I have a mixed background as well. I only became a nurse later in life. In my late 20s,
Okay.
I started my training. So there is a few of us rolling around with the different backgrounds. But I was wondering, I guess for nurses who maybe know nothing about AI and want to learn a little bit, what would you advise them to do, I guess, in terms of trying to get to grips with AI, whether they're maybe in practice or maybe in education?
Yeah, that's a great question. I mean, I do feel there are a plethora of resources out there, right? Like there's your amazing network, which is really great. And I think there's a lot of free education opportunities out there. Some of the big universities are offering, some of these open classes about AI. I know Duke has some specific to nursing, for example. And I'm trying to think. And there, obviously there's a lot of good papers out there, but it can be overwhelming, right? Like even myself, like there's so much out there. It's sort of hard to know like where to even look. I'm reading about this all day, every day, and I also feel like I'm only just scratching the surface. So I believe, many professional nursing organizations are now trying to get the word out. So wherever you are, that's probably a good place to go. I mean, if you get involved in, like that nursing knowledge big data science group that I talked about, or looking for other nursing informatics organizations, we don't expect experts at our table. We love students. We love direct care nurses. I haven't done direct care and it's probably been about 8 years now, right? So I love to hear what's happening for real today. That's super informative to me. So don't feel, I think, any nurse shouldn't feel like, oh, I don't have expertise to take part in that group or do that. It's like you do. You have expertise in nursing practice, your patient population, the data you create. We want to work with you, right? So those of us who are now more in the research space, but still really care about what's happening at the bedside. So I would just say, don't be afraid to get involved. That can be just a great way to learn with others. You've got something to bring to the table. So yeah, just show up. I mean, of course, there's more and more formal education programs out there. There's even, like in the US, some master's programs focused on AI for nurses.
Great.
So those things are out there if you really want to formalize your education in that space. But I think there's a lot of opportunity but again, I recognize it gets really almost overwhelming. There's so much out there and it's changing so fast. There's some podcasts, that I listen to, even with it, like it's just try to find people that you feel like you kind of trust and vibe with, and then follow along with them. Yeah, lots of opportunity. I didn't include it. I do have some slides where I have some resources, so anybody can reach out to me and I'm happy to provide more specific recommendations. But your network is a great one.
Oh, thanks, Anne. Yeah, there's loads of great resources out there. And I think, yeah, starting small and taking it bit by bit, because it is very overwhelming. There's loads of jargon and to get to grips with.
Yeah.
Yeah, I always compare it to starting your nursing career. There's loads of medical jargon you didn't know anything about. And it took you a couple of years to get your head around it and get going. So
Totally.
the same as with AI. Don't get put off. You'll get there eventually. And my last question was, I know it's kind of difficult to predict, but where do you think AI might go in the future, and what kind of trends should nurses be looking out for?
Yeah, I feel like for nursing, I'm seeing a lot of the ambient type of AI seems to be what what's feeling very very of interest, and not just the ambient listening, but also now I'm hearing more and more about companies bringing in like the video feed. So, or, having nurses, researchers talking about having nurses just wear the AI glasses all the time and record everything they're doing. Which again, probably like if assuming you could have that work, it could probably record all that you're doing in the room for you and document. But again, we think as nurses, we just need to think about the other side and what that means to be recording either auditory and or, visual feed in patient rooms, thinking about the fact that those are sacred spaces and what does that mean for the nurse-patient relationship and patients confiding in us. I even wish like my own, primary care provider uses AI during our office visits. And I wish at the end she would turn it off and be like, hey, now that that's off, is there anything else you want to talk about? So again, I think there's a lot of interest because of the documentation burden. But I hope we'll be really thoughtful about it and also think about, do we need to be documenting everything we're documenting, right? There's some like core things to ask, but not just like screw AI on top of our current systems just because it's here. So again, I'm curious about all those things too, but hope, we'll have direct care nurses right alongside us along the way to think through the many sides. I mean, the other, ethical concern related to AI that I think we're watching, at least in my state that I showed you in Wisconsin, we have a lot of water. We have like over 10,000 lakes and we're onto the Great Lakes. So we're of real interest to data centers and these hyperscale data centers. Again, data centers have been around a long time. Littler data centers, not a big deal, but we're starting to see hyperscale data centers for AI that are like bigger than airports, right? Just, lots of farmland, lots of environmental concerns, lots of human health concerns in the proximity of where these are at. So some of us nurses in Wisconsin are really starting to watch that. And I think there's, probably a lot of opportunity to study, and that kind of brings me back to my own background, right, in environmental health and science, and thinking about maybe combining the two and keeping an eye on those hyperscale data centers and what that means for the communities where we live. So that's another one off the top of my head that I'm kind of noodling about a lot.
Yeah, thank you. Yeah, it's really important to mention the kind of impact on the planet and climate change. So, because it's happening
Yeah,
everywhere. So,
right.
yeah, I think it'd be great to get more nurses involved in this area of research and practice because it's so huge and fast moving and will definitely impact all of us, regardless of where we are or what we're working on. So, great to hear so much about your work, and it sounds
Yeah,
brilliant. And hopefully, we might check in with you in a year or two and see where you're at.
sounds good. All right. Thank you so much for the invitation.
Great. Thank you so much. Bye.